corticosteroids for acanthamoeba. But I'll take a few minutes now to go over some of the way that we manage herpes keratitis infections at the Proctor Foundation. Let me share my screen.
Good. It's good.
All right. Yeah, it's working.
Yes, it is.
Okay, good. So, so some of this, will be a bit of a review, but herpes virus, it's a 200 nanometer diameter double-stranded DNA virus. And, as people are infected through the ocular oral mucous membrane. It travels retrograde up the nerve into the trigeminal ganglion, and it establishes a latent state in the trigeminal ganglion, and then we get chronic disease as virus is shed from that latent state in the trigeminal ganglion over the years. And besides this trigeminal ganglion latent state, there is some animal evidence that there may even be a latent state that can develop in the cornea itself. And so for this lecture, I wanted to go over just the basics of diagnosis clinically, and then with testing, as well as the way we manage, and then the way we prevent herpetic keratitis. So we'll start kind of, traditionally we kind of discuss herpes keratitis as epithelial disease, which you see on the left-hand column there, stromal keratitis, which is in the middle column, and then endotheliitis or disciform keratitis in the right-hand column. And so the epithelial disease is really characterized classically by a dendrite. And a dendrite is going to be a branching structure. The classic thing here is it has terminal bulbs, which you can see nicely in this retroilluminated picture. And if you were to scrape the epithelium there and look under an electron microscope, you'll see all of these viral particles in the epithelium. So, a dendrite, the cells of the dendrite are actually infected with herpes virus, and we need to be, attacking the virus in our management. So we need to use antivirals when we're dealing with dendritic keratitis. The classic thing people talk about is that the fluorescein will stain the bed of the dendrite, and then lissamine green or rose bengal will stain the edges of the epithelium. And the reason for that, so there's a loss of epithelium with the dendrite, and so the basement membrane is exposed, and that's what the fluorescein is staining. Whereas the sort of border cells of the dendrite are sick, and so they'll pick up stain from the rose bengal and from the lissamine green. But these kind of the herpes dendrite is a very characteristic looking thing, and you almost don't really need any further testing. If you see the characteristic herpes dendrite, you know that it's herpes. But you can get some other conditions that look like dendritic keratitis. This is a patient who had zoster keratitis. And we call these pseudodendrites because they don't look like a classic dendrite. There's no terminal bulbs. You can tell that this is almost kind of a mucoid appearance. It's kind of stuck on. There's no loss of epithelium. It is picking up a little bit of stain, but it's elevated actually off of the cornea. So these pseudodendrites, if you see something like this, it's, you should really think to yourself, that's probably not a herpes simplex keratitis. There's probably something else. One other thing to mention, we talk a lot about pseudodendrites in acanthamoeba keratitis, but in that case, it's really more of like an epitheliopathy that sort of has a kind of dendritiform appearance, but it's not so much either elevated or a loss of epithelium as much as just kind of a staining pattern that you're looking at with the pseudodendrite of acanthamoeba. One thing that's kind of interesting is that when you have patients who are on treatment for herpes keratitis. So for example, this patient was on oral acyclovir, but had a breakthrough epithelial lesion. And when we swabbed this, it was positive for herpes simplex 1. And the take-home message here is that when you are on an antiviral, the dendrite will sometimes not look classic. So you can get kind of blunted edges and just more of a diffuse picture here, rather than the terminal bulbs and kind of the beautiful dendrite that appears when you're not on antivirals. So if you see an epithelial lesion on someone who is on an antiviral, you should proceed as if it is actually live active virus and kind of escalate your antiviral therapy. So this is an example of epithelial disease that has not been controlled with an antiviral, and maybe this patient was put on a topical steroid. That's a sort of a risk factor for this presentation of a geographic ulcer. And a geographic ulcer is kind of like a dendrite that has not been controlled, and so there is still going to be live active virus in the cells surrounding the actual geographic ulcer, but it's just gotten kind of like a bigger appearance. So that's another epithelial presentation. And then one final presentation just to mention is that of a neurotrophic corneal ulcer. So this is a little bit different. We don't think of there being live virus and a neurotrophic ulcer. Rather, this is because of loss of corneal innervation from the herpes keratitis. And so classically a neurotrophic ulcer will be kind of in the inferior third of the cornea. It looks oval, often heaped up edges along the margin of the ulcer. And these can be very difficult and challenging to get to heal. So now moving into the stromal keratitis. So with stromal keratitis, what we're seeing here is really an immune reaction. So these are electron micrographs taken by Chan Dawson, who is a former director of the Proctor Foundation. And if you look, you can see kind of some like round viral particles. These look a little bit different than the pictures I showed before. And our thought is that in stromal keratitis, it's not that there's live virus, but rather there was previous infection. There's these viral particles that don't get completely cleared from the cornea, from the keratocytes, and that serves as a stimulus for an immune reaction from your own host immune system. And so the stromal keratitis is really just your body trying to clear these viral particles and causing inflammation in the cornea. And so the things that we see with stromal keratitis are infiltration. The infiltration, it looks different from a bacterial keratitis, where it's more of bacterial keratitis will be more purulent and more dense. This is more of a cellular infiltrate, where it's more hazy. It can get dense, but it looks different than it's not like a soupy infiltrate like you might see with a bacterial ulcer. So besides that, there's usually no epithelial defect with a stromal keratitis, interstitial keratitis, compared to a bacterial ulcer. And then there can be blood vessels that form with the interstitial keratitis as well. Herpes simplex virus is going to be the most common cause, at least in the United States, of interstitial keratitis. So if you see a patient, it's a good hunch that it's herpes that's causing it. One finding that we've noticed through the years is something that we call steel wool keratopathy. So this is a kind of metallic polychromatic appearance of the stromal infiltrate, stromal scar. This doesn't go away with time. This will always be there. But if you see a polychromatic tinge, it makes us think of herpes keratitis. It's probably the case that any chronic keratitis can cause this, because it's just some changes to the collagen of the cornea, but it does put herpes on our radar when we see these steel wool keratopathy changes. So oftentimes with stromal keratitis, there is no epithelial defect, but you can get necrotizing stromal keratitis. And with necrotizing stromal keratitis, there is in fact an epithelial defect, and the infiltrate here, you can tell, does look a little denser. And in this case, normally we think of stromal keratitis as an immune reaction only, not really live virus. But in the case of necrotizing stromal keratitis, there is live virus, and it's kind of like a combination of an epithelial disease plus a stromal disease. And these also, in my experience, are kind of more likely in people who might be immunocompromised and where their immune system is not able to clear the virus very well. All right, and then what about endotheliitis? So endotheliitis is just as it sounds. It's infection of the corneal endothelium with herpes simplex virus. And the key findings are keratic precipitates. These are often centrally located, and then you get an overlying area of corneal edema. But it's usually round and central in the cornea, but it can also be linear shaped or other shapes as well. One other key finding that often happens with endotheliitis is that the intraocular pressure goes up. And the reason for that is because there's a trabeculitis and infiltration of inflammatory cells in the trabecular meshwork. And so I think I have one more picture. Oh yeah, here's kind of a nice picture where you can see the keratic precipitates in the overlying corneal edema. And I think maybe in the past people called this disciform keratitis, but nowadays we call it endotheliitis. And like I said, you can also get some more linear pattern or just not quite centrally located in the cornea. All right, so when we talk about diagnosis of herpes keratitis, it is primarily a clinical diagnosis that you're diagnosing just on on slit lamp exam. But there are, certain tests that can be helpful. So on exam, it's helpful to test for corneal sensation. And so a key finding with herpes eye disease in general is that there's reduced corneal sensation. And classically, this would be like a focal loss of sensation for herpes simplex virus, whereas it's a diffuse loss for varicella zoster virus. It's not always decreased in stromal or endothelial disease. So just, if you have a patient with an interstitial keratitis and you think that it might be due to herpes, but their corneal sensation is normal, it still could be due to herpes. The decreased corneal sensation is going to be most notable in people with epithelial disease. And then the way we test at Proctor, we like to use the Cochet-Bonnet esthesiometer, at least, in the beginning when we're diagnosing people. It's helpful because it gives you a number between 1 and 6, so you can kind of gauge how much loss of corneal sensation there is. And when I do the Cochet, I like to do the Cochet-Bonnet at the actual slit lamp so I can see exactly where I'm touching on the cornea. And that way, if there is an area that you want to make sure you test the corneal sensation of, you can see exactly where you are. But we always will test centrally and then in 4 quadrants of the cornea. If you don't have the Cochet-Bonnet, one easy way, you can use sort of a cotton tip applicator, the wisps of a cotton tip applicator, but another thing that we use is dental floss. Like waxed dental floss is nice because it is a little bit firm, and so it will give you a nice measure of corneal sensation. So the loss of corneal sensation is usually going to be unilateral, but you can get bilateral loss of corneal sensation in about 1% of adults and 10% of children. And this, in the setting of herpes, this usually happens if there's a coexisting immune condition. So people who have atopic dermatitis or rosacea, they have an innate immune problem, and they're less likely, they can't clear the herpes infections quite as well. And so those people are the ones who are most likely to have bilateral disease. What about getting antibody testing for herpes? I would say that in general, we don't think of this as being very helpful. The reason is because the seroprevalence to herpes simplex 1 is very high. This was a population-based study that was done in the United States. You can see they did a round of sampling like in the early 2000s and then 10 years later. Interestingly, the seroprevalence is going down, especially among adolescents, but even among adolescents, just a high proportion of the population has been exposed to herpes simplex virus. So a positive test, it doesn't really tell you that the eye disease is due to herpes virus. And then also it's hard because a negative, we've seen patients who've had negative tests for antibodies, but a positive test when we swab their epithelium for PCR. So it's not a perfect test. Some people like to get it to sort of rule out disease, but just realize that there are cases where they'll be antibody positive, but it's still herpes. What about other kinds of scraping the cornea and then doing stains? So the top left picture here is showing a Giemsa stain where you'll see multinucleated giant cells. This can be effective, but it's only about 50% sensitive. Just doing conjunctival scraping and looking with Giemsa. There are, immunohistochemistry, which is shown on the upper right, or immunofluorescence on the lower left. But really, the way we test for herpes, in 2024 is with PCR testing, shown on the bottom right there. The PCR testing, the thing to know about this is that it depends on the lab that's doing it. And so the sensitivity and specificity of the assay has to be set according to the copy number of the PCR. And so you can get a lab that has set their assay so that it's too sensitive. And so it's possible that you can get a false positive from someone who has been exposed to herpes and maybe has some viral shedding, but their eye disease is not due to herpes. So it's just something to be aware of, to kind of know the lab that you're working with, where you're sending your PCR test, just to ensure that they're not setting their assay too sensitive or not sensitive enough. One other important point about PCR testing is that if you put lissamine green or rose bengal in the eye prior to taking the swab, that can inhibit the PCR reaction. So that can cause a false negative PCR reaction just because of the lissamine green that you put in. This does not happen with fluorescein. Fluorescein does not inhibit the PCR, but it's just something to be aware of if you do put lissamine green or rose bengal in, and then you did want to get PCR afterwards. You may want to rinse out the eye with some, BSS or something like that. Another diagnostic test that we probably don't think of all the time with herpes is to use confocal microscopy. And the confocal, especially if you look at the endothelium of the confocal, there are some characteristic signs that we see in epithelial, stromal, and endothelial keratitis. And just to go through these briefly, in the upper left in A, the single arrow is pointing to pseudoguttata. Those double arrows are looking at increased intercellular gaps. And then in B, the upper right, we can see just diffuse inflammatory cell infiltration in the endothelium. In C, you see loss of the endothelial cell borders, and you can get these, they call spot-like holes, which there's an arrow there. And then in D, a larger kind of hole with just complete denudation of the endothelium. So they found that when they looked at 250 patients, that there was definitely overlap of people who had endothelial disease on confocal, and also they noticed the endothelial findings on slit lamp. But there were lots of patients who they saw the endothelial disease on the confocal. So it's just something to keep in mind that these are findings that when you start treating the patient with steroids and antiviral, these endothelial findings will get better. So that they do seem to be actually correlated with the disease process. The other interesting thing is that you can see this even in 25% of patients with just epithelial disease or anterior stromal disease. also had these endothelial findings, which is just telling us we should, be promptly treating these people because there may be endothelial damage that's happening even in more superficial types of herpes keratitis. And we obviously do not want the, endothelial damage to be happening. All right, what about treatment? So, one of my mentors is Jack Witcher. He was also a former director of the Proctor Foundation, and he spent some time in Tunisia early in his career. They had a lot of herpes simplex in Tunisia, and he did a study where he just debrided the dendrite. And then patched the eye. And he followed many patients like this. And on average, the median time to healing was about 5 days. But then since that time, there's been lots of other, lots of medications that have been developed for herpes. And the ones I'll just kind of call attention, the blue and green line are acyclovir and trifluridine, which are kind of the more common topical agents that have been used, throughout the last 50 years or whatever. And from this graph, what you can see is if you draw a line over from the 50% line, that like at about 1 week is what we can expect half of our patients to have healed. And then if we look kind of by 2 weeks, up here is maybe like 90% of patients should have healed if they're on acyclovir or trifluridine by 2 weeks. So that's nice just in terms of being able to counsel our patients, what they can expect in terms of their the time until healing. And then there have been, what's not shown on here is there have, recently been more studies using ganciclovir gel. So for, in the United States, we don't have acyclovir ointment, but we do have ganciclovir gel. And so ganciclovir is, has, pretty similar efficacy to acyclovir ointment. Here are some data from the trials that were used to get it approved by the FDA. And you can see that the cure rate at 7 days exceeded, 70% in these trials for both ganciclovir and acyclovir. And when they reanalyzed the data, looking at it as a non-inferiority, so here, if ganciclovir is better, that's going to be above the dashed line. And if acyclovir is better, it's going to be below the dashed line. And so you can see that, there's not that much difference. The difference is within sort of 15 to 20 percentage points on either side. And it doesn't seem as if one is really all that much better than the other. So these are topical agents for epithelial disease. What about oral agents? So there haven't been that many head-to-head trials looking at oral acyclovir versus topical acyclovir. There is one trial that was done in the UK back in the 1980s. And here you can see that the two lines, the kind of the white circles there are oral acyclovir and the black circles are ointment. And they track pretty closely. There wasn't that much of a difference in healing between the oral and the topical. And I guess before I move on to the stromal keratitis, I would say for our practice pattern at Proctor is that we prefer oral acyclovir over topical preparations. And so generally what we like to do for epithelial disease is to debride the lesion. The idea being trying to remove the actual viral particles and then treat with an oral antiviral to prevent any, to cover any virus that we've missed, and then also to prevent virus from, reestablishing. And this is usually pretty successful. And we like that because that way you don't really have to deal with any epithelial toxicity from any of these agents. I think, acyclovir is not as toxic, but for many years we just had trifluridine in the United States, which is very toxic and just causes more problems. So using oral acyclovir, you sort of bypass any problem with epithelial toxicity. Okay, so moving on to stromal keratitis. So this is a graph from the HEADS trial, stromal keratitis trial. So these were patients that had stromal keratitis. They treated them with trifluridine topically as the antiviral, and then they randomized them to steroids versus placebo. They gave them a 10-week course of steroid or placebo, and then the outcome was if they failed treatment, if they had a recurrence of inflammation. And so you can see there is this huge difference between the steroid group and the placebo group, and the steroid group, shown on the top line, was much less likely to fail treatment over the 10-week period. But something that was kind of interesting is that they forced, according to the protocol, you had to stop the study drug, either the steroid or the placebo, at 10 weeks. But they did then follow people for a little bit longer after they had stopped. And you can see that steroid group, originally during the first 10 weeks, they did great. But then once they stopped the steroids, so many of them ended up failing and having recurrence of their inflammation. So this is telling us, that we probably need a longer treatment duration than just 10 weeks of steroid. And in fact, a lot of these patients, especially patients who have blood vessels, who have an interstitial keratitis with blood vessels, these patients are going to need really long-term steroids. And so let me go to the next slide here. So here's a patient who had a necrotizing stromal keratitis. We started this patient on Valtrex, 1 gram twice a day, and then a topical steroid, prednisolone, 1%, at 4 times a day, and brought them back in 4 weeks. And the epithelium had healed, the sort of purulence was much less, the density of the scar was much less. The blood vessels had regressed, so looking a lot better. And sometimes we'll get a patient like this referred into us from an outside doctor who maybe was happy with this result and then just stops the steroids. But then the patient recurred, and the patient will come into us, and the doctor will say, well, we can't get the patient off of the steroids. And so we have a different approach. We don't try really to get patients off of steroids. If they have stromal keratitis, the way we think about this is that patient needs steroids. So we don't want to necessarily get them off of steroids because they need the steroids. But instead, what we want to do is get the patient on the lowest possible dose of steroid that's going to control their inflammation. And by getting them to the lowest dose, we're going to reduce any chances of side effects, but also adequately treat their inflammation so that they don't have any longer-term complications, and also just so that they're not constantly flaring all the time. And so the way that we do that is that we don't make changes to the medication sooner than 4 to 6 weeks. So if we had this patient on 4 times a day of Pred Forte for 4 weeks, then we would say, well, why don't we go down to 3 times a day or 2 times a day, and we'll see you back in another 4 to 6 weeks. And at that point, if they look good, then we go down again to once a day for another, and then see them back in 4 to 6 weeks. And we keep repeating that, and we'll go down, like after they're on for once a day, we'll go down to Monday, Wednesday, Friday, and do it 3 times a week. And we just kind of keep doing this very slow reduction in the steroid. And then the nice thing, the reason we do it so slowly is that we find that sometimes you might go down, let's say we go down to twice a day. The patient does fine for the first week, but then during the second week, the keratitis starts to come back, and they start to flare a little bit. And so if you do the reduction too quickly, you don't really ever know how much steroid is the lowest amount that's going to control their inflammation. But by doing it really slow, it sort of controls the process much better. Some tips that, in terms of just our approach for using steroids. One is that you should always use concomitant antiviral. So if your underlying diagnosis is herpetic keratitis and you're using steroids, you always want to be covering them with an antiviral at the same time. And for us, that means an oral antiviral. And so when we're managing someone with active disease, that means Valtrex, 1 gram twice a day or 3 times a day, even depending on how bad the infection is. And then if it's someone who, they're quiet and you're just kind of doing this like very slow reduction in the steroid, then we'll use Valtrex 1 gram once a day. One thing for us is we don't use the word taper. When you say that you're tapering steroids, the connotation is that the patient does not need the steroid anymore, but you don't want to suppress their adrenal glands. But like I just said, the way we think about this is that actually the patient does need the steroids. And what we're doing is not so much tapering them off for safety reasons, to do a taper, but rather we're actually trying to titrate the steroid. We're trying to find what that lowest dose is that will control the inflammation. And like I said, we typically don't do this more quickly than every 6 weeks, as one will make a reduction in the dose. All right, and so the take home for stromal keratitis is that we need steroid, we need to use it for a long period of time, and we need to cover with an antiviral when we're treating. And then for endotheliitis, really the HEADS trials lumped endotheliitis in with stromal keratitis, and we can approach this similarly. Like I said, there is live virus with endotheliitis, so you definitely want to treat with an antiviral, but there's also inflammation, there's edema, so we do treat with topical steroids as well. And we manage it, very similarly to stromal keratitis. One thing to note with herpes ocular disease, when you do get an increase in pressure because of the tracheobacterlitis, usually we won't start intraocular pressure drops, because usually just using a steroid, you'll reduce the trabeculitis and then the pressure just comes down with the steroid alone. So that's like one less thing for your patient to have to worry about. I think you don't really need to start a pressure drop. This all depends on the clinical situation, of course, but like just in general terms. All right. So what about prevention? So the HEADS trials, they looked at recurrent disease. And so these are patients who had stromal keratitis, and then they followed these patients for a year, and half of the patients got acyclovir. And at this time, at the time of the HEADS trials, people didn't really know what the appropriate dose should be. So they used 400 milligrams twice a day of acyclovir. And with that dose, you can see that it reduced by half compared to the placebo group the chance of getting a recurrence of stromal keratitis. So it's definitely effective. And, nowadays we would use much higher doses than 400 twice a day. So hopefully, nowadays it's even more effective than what this is showing. So this is long-term, daily acyclovir for a year. And the HEADS trials, they did a different study where they looked at recurrence of any ocular herpetic disease. This is again showing the recurrence over a year, and the bottom line is the acyclovir and the top is the placebo. They then had everyone stop their study drug at a year and followed them for longer. And interestingly, it wasn't really the case that the acyclovir group, now these are people who had received acyclovir for the first 12 months, but then during that yellow bar, they were no longer receiving acyclovir. And so you might have expected that all of a sudden there'd be a lot of recurrences in that acyclovir group and that the slope of that line would go up. And it maybe did go up a little bit, but maybe not as much as people thought. So then some people, sort of are not sure, should we only be using 1 year of acyclovir because that's what the HEADS trial showed. I think, for us, we like to use longer courses of acyclovir. And part of the reason is that we are shedding herpes simplex virus all the time. So there was a study done a while back where they took 50 people, they did not have any ocular herpes lesions at all, and 3/4 of them were IgG positive for herpes simplex virus. And they had these patients, they gave them a whole bunch of conjunctival swabs, and then the patient would swab themselves twice a day for 30 days. And so this graph on the bottom is showing all 30, each bar is a patient, and it's saying the percentage of each of those, 60 swabs that was positive for herpes simplex virus. And you can see that, and again, these are people who don't have any eye disease, but you can see a lot of them are shedding virus, a lot of the time over the month. This is taking an example, same study, looking each is a patient. The top one is a patient, the middle is a patient, and the bottom is a patient. And it's looking at their morning and afternoon swabs across the 30 days of the month. And so you can see it goes, up and down. That some days they're shedding and some days they're not shedding, and that there's variability, so that the patient on the top is shedding a lot, whereas the patient in the middle, does not shed quite as much. But this is all evidence to say that there's shedding happening all the time. It can be hard to predict when the shedding is happening. And so if, the thing that's going to be causing epithelial keratitis and an endotheliitis is viral shedding from the trigeminal ganglion. And so we really to prevent that disease, what we want to do is we want to prevent that viral shedding from happening. And so in order to do that, we need to have an antiviral on board that's going to have really good bioavailability, that's going to be at sufficient levels for most of the time of that month, so that at any given time when the trigeminal ganglion may want to be shedding some virus, that's going to prevent that from happening. And so, for this reason, we sort of at Proctor, we just treat people basically lifelong. I mean, once they have herpes, we just tell them they should be on antiviral for the rest of their life. And we like to use Valtrex as opposed to acyclovir. So this is a graph looking at the sort of bioavailability of acyclovir is the sort of that bottom solid line. And this is, across 24 hours, that's 5 times a day dosing of the acyclovir. And then the top dashed lines are valacyclovir or Valtrex when you give it 4 times a day. But you can see how the bioavailability is just so much higher for the Valtrex compared to the acyclovir. And to get an equivalent dose, you have to take 800 milligrams of acyclovir 5 times a day versus 1 gram of Valtrex twice a day. So the dosing regimen is just much easier with Valtrex, and you get higher bioavailability. And in the past, Valtrex was more expensive, but nowadays, I don't know in Brazil, but in the United States, it's usually not so expensive anymore. So there's I think, little reason to put people on acyclovir anymore. I think everyone should be on Valtrex. What about, and we're talking about long-term Valtrex here. I told you, we tell people they'll be on for the rest of their lives. So what about certain, special situations like pregnancy? There have been studies. So there was a population-based study in Denmark that had, 800,000 live births, and they looked at, all the medications. They have I guess in Denmark, they know exactly all the medications that all their citizens take. And so then they divided women into those exposed to the antiviral, that's the bar on the left, and not taking an antiviral on the right, and then measured the percentage of major birth defects. And you can see it was about the same, just a little over 2% for both of those groups, and the odds ratio, was not significant. So it seems like, being on an oral antiviral is not really having teratogenic effects and not causing any problems. So it seems like it's safe to continue use of acyclovir or valacyclovir during pregnancy. What about resistance? You might think like, well, wait, should we really be having these patients on such long-term antiviral? Isn't that just going to select for a resistant virus? So acyclovir resistance, it is a problem in patients with HIV. So it is something definitely to be on your radar for your HIV patient who's immunocompromised. But in someone who's immunocompetent, it's really uncommon to get acyclovir resistance. To take a step back, so acyclovir requires phosphorylation by herpes simplex virus encoded thymidine kinase, and that is encoded by the UL23 gene. And so usually when we're talking about acyclovir resistance, we're talking about resistance in this UL23 gene. And there should be cross resistance against acyclovir, valacyclovir, which is just a prodrug of acyclovir, and famvir. All 3 of those theoretically should be affected by this resistance in the UL23 gene. If you wanted to use a antiviral that does not have the thymidine kinase, you could use foscarnet or cidofovir, but these are not as safe of medications as acyclovir. So for us, if we have a patient who we feel like, I don't know if that, you're on the maximum dose of Valtrex, and still they seem like they're not able to clear the infection, well, we'll usually switch them to famvir, which doesn't really make much sense because it's a similar mechanism of action. And like I said, if it truly was resistance, it should, if it's resistant to valacyclovir, it should also be resistant to famvir. but we do find clinically somehow that like oftentimes that can be helpful, that if they're not responding to the valacyclovir, sometimes they will respond to the famvir. So that's something to consider before trying one of these other antivirals. But in general, and then also just in general, we don't think of this as being such a huge problem. It's important to know about the relationship between atopic disease and herpes simplex virus. So atopic patients are going to be more likely to have bilateral herpes disease and also more severe disease. They're going to need higher doses of antiviral, and they're going to need to be on antiviral for a longer period of time. So it's good to just educate them about this, that their disease will be worse. And again, the reason for this is because atopy is inherently an innate immune problem. And so there is a problem with our immune system's ability to clear the herpes virus. And so like anyone along the atopic spectrum can be more likely to have, worse herpes keratitis, but the association is the strongest for atopic dermatitis, and it's a weaker association for asthma. So the conclusion, just in terms of treatment for these conditions, is that when we have a dendrite, epithelial keratitis, what we do is usually we'll debride the lesion and use an oral antiviral. You can also use topical agents. For stromal keratitis and endotheliitis, we're using oral antivirals plus a topical steroid. We want to use steroids early so that we're preventing endothelial damage and scarring in the stroma. We want to find the lowest dose needed to control the inflammation, and we want to go very slowly when we reduce our steroid and find the lowest to find the lowest dose to reduce any potential side effects. And then in terms of acyclovir or valacyclovir prophylaxis, we have our patients on that sort of lifelong, and usually at a dose of 1 gram of Valtrex once a day. And then if they have breakthrough disease, then we can increase the dose of acyclovir. So I think that's all I had prepared for today. So thanks a lot for your attention, and I will stop sharing my screen here.
Wonderful, Jeremy. Thank you so much. Excellent lecture. I have so many questions, but I'm going to ask people if they want to make any questions, or maybe I'll do my questions and then we see.
I have one, Denise.
Okay, go ahead. Professor Ana Luisa. Jeremy, I think you remember her. She's our chairman.
Yeah, of course.
Hi, Jeremy. How are you? Thank
Good,
you for coming and give us an excellent lecture. I have a question for you regarding patients with stromal keratitis that need steroids, but they are a responder with high pressure, and it's not a case of trabeculitis. What would you do?
I mean, we would just start them on, the typical topical medicine. So, and we, it's funny because I think there's this thinking that like prostaglandin analogs are not good to use in patients with ocular inflammation because they may cause more inflammation. But in our experience, we do not, we have a lot of uveitis patients that we put on prostaglandin analogs and don't see any problems at all with that, increasing inflammation. So we would just use, your typical beta blockers, just, prostaglandin analog, any type of topicals. But then we do have patients who, that doesn't work, and then they get surgery, and then we'll have, they will get, and usually for patients with, our glaucoma service refers to do tubes for a patient that has, any type of ocular inflammation. And yeah, sometimes, but I think the hard thing is they need the steroid. Like there's no, it's like the only option is if they can get away with drops, great, and if not, they need surgery.
Okay,
so,
and tacrolimus.
Tacrolimus to use for instead of steroid. I guess I will say I think that's something worth considering, definitely. And if you can get away with that and the patient responds, then that's great. I guess in our experience, oftentimes I just find that tacrolimus doesn't work quite as well as topical steroids. But I think it's a good thought to try that, some first.
Okay, thank you.
Yeah.
Wonderful. Jeremy, let's go. Any situations, particular situations that you use famciclovir?
Yeah, we do. Like, I would say we generally start with Valtrex. Some of that is because of the bioavailability, but also the cost. But mostly, we do have some patients on famciclovir. It's mostly patients for whatever reason we thought their Valtrex wasn't working that great, and then we try them on famciclovir. But I don't tend to think of it as being any different. I sort of feel like Valtrex and famciclovir I kind of put in the same category of antiviral. So. Yeah, I treat it the same as being on Valtrex.
I do the same, but once in a while I receive some patients, very severe patients, the atopic ones, that some friends decide to start with famciclovir. That's why I'm asking you. I always try first acyclovir or valacyclovir, depending of the price, and you know if you can pay or not. But my use of famciclovir is really rare, you know, just very peculiar cases. I don't do this, but I want to know your experience. And we have a problem here because we have mother or father with, you know, lips HSV, and we try to tell them not kiss their tooth. But, you know, it's a very difficult condition. Would you think about putting them in oral prophylaxis because of this, you know, family situation?
Interesting. Like if they didn't have eye disease, if the kid didn't have eye disease, but the parents had, well, you know, I guess maybe it would depend on how bad the parent's oral disease was, you know, like if first of all, the parents should be on prophylaxis. I mean,
that's right.
Yeah, that would probably be what I would do first, is like to educate them and like put them on prophylaxis as opposed to putting the kid on prophylaxis. But they're very safe medications. So, besides the cost, that's the biggest thing. But otherwise, I wouldn't have any real problem with that,
And yeah, and the Brazilian government, they provide the acyclovir, so we always like to, give to them as prophylaxis because it's a very hard situation, it's a family problem. So, and I already asked about tacrolimus. I have the same feeling. It is corticosteroids. Nothing else will work as good as corticosteroids. But sometimes in a long run, maybe I'll start with corticosteroids and then switch to tacrolimus. But I don't know if it's a good idea, I really don't know. But there is no
Are you using tacrolimus ointment, or can you get drops made here?
We have ointment.
Okay, so you have them use it before bed or something like that?
Yes. Otherwise, we can manipulate. We can do in a pharmacy as drops, but we use more.
I think it's not. I think if the patient can be controlled with tacrolimus, then that's great. And then if they do have breakthrough and you need to use topical steroid for like a short period of time when they have breakthrough, I think that's good. Maybe I've just been conditioned to think about. Maybe I haven't been as open to that, but maybe we should try it. I think it's worth trying these like other agents, these steroid sparing agents.
And also we have some difficulties with ointment because the patients don't like to use ointment. And gel, I think it's a very nice indication, I don't know why they don't do gel. Usually everybody goes to ointment. I think we should, just say people maybe would be better to use, gel for these patients. And in relation to resistance, I'm always worried with this. But I don't see any resistance, even in HIV. I know the papers are saying, calling the attention for HIV patients, but I don't see any resistance.
And even in HIV, my sense is that was a lot with sort of CMV retinitis. Those patients, the resistance for patients who are on like long-term ganciclovir, that was a problem with the resistance. But yeah, I don't know, just clinically, we don't see it as being a problem. Like I have had a couple patients who have been immunocompromised, and we've wondered, they had a hard time clearing. But even them, I wasn't sure if it was so much that there was resistance or just that the patient's immune system was having a hard time clearing the virus, like that they would have a hard time clearing any virus, resistant or non-resistant. So, yeah, I don't know. I think just clinically, we don't see that being such a big problem. And the other thing is you can increase, you can go to pretty high doses of the antiviral. So, you can, go to Valtrex 1 gram 3 times a day. And sometimes you can even do Valtrex 2 grams 3 times a day, which approximates IV dosing. And if you do that, though, be careful. We've had a couple patients that have had kidney issues after we've done that. So you want to be careful if you're going to do it that super high dosing. But otherwise, I don't know. We don't worry about that too much.
Okay, you don't do any KISS tests for any kind of dosage of oral acyclovir, or no?
We don't tend to, unless we know the patient has pre-existing renal disease, but otherwise, no, that's not in our standard, to check a BUN and creatinine before starting. We don't. We just go ahead and start it.
Okay. Another point, once in a while, we get a patient who wants to do PRK or LASIK, and they have herpes. We usually say no to them, but do you see any chance to open a door for those patients, giving, prophylaxis and maybe long-term use of antivirals before and after the surgery, or never, ever do LASIK or PRK in those patients?
Me personally, I would try to convince them not to do that. I think I would just be nervous that you're just going to create more problems. Because I'm sure you could get away with it, right? I'm sure there's going to be a certain segment of patients where they, have mild disease, and like you said, if as long as they're on prophylaxis and they're on a good steroid treatment, that they'll do good. I'm sure that there are patients like that, but I would just be worried. What if this is the one patient who's going to do really badly, and then you caused this to happen? So I don't know. I would discourage people. Yeah.
Yeah, me too. I never ever do. I don't want to have any problem myself with those patients.
Yeah.
And also, in relation to PK, do you put them on oral prophylaxis for how long after the surgery, after corneal transplant?
Yeah, definitely. We would put them on high. You're talking about for some antiviral prophylaxis?
Yes, antiviral prophylaxis.
Yeah. We would definitely put them on high dose, probably 3 times a day, sort of for a couple weeks before and for at least a few months after. And then probably go back down to, once or twice a day after a few months.
Okay, good.
I think it makes sense, it's safe medicine, might as well just give them a higher dose at the time of surgery. Yeah.
Okay. And I think, well, let me say myself, I feel very comfortable treating adults, but children, I'm always afraid about the dosage of the antiviral. Do you have any tips on this? It's very difficult.
Yeah, it's weight-based. I forget exactly. I want to say I forget exactly. So I would always have to look it up. But look it up. It's let's say 200 mg per kg or whatever it is. There's you have to weigh the child. But I think with that, as long as you are following that weight-based recommendation, then I think it's okay.
But would you be worried that maybe children would have more side effects of the use of prolonged oral acyclovir or not?
I guess I don't really worry about that, but I guess, we could ask their pediatrician, but I don't see why it would be any different, for the child compared to the adult, especially, if they're getting the dose, the acyclovir has to be, has to have that thymidine kinase. So it has very little effect on the human cells unless the viral thymidine kinase is there. So I don't know. I guess I wouldn't worry too much about that. I feel like maybe it's that the benefits are probably better, especially in a kid where if they're going to have recurrent, ocular herpes, they could really, lose vision from that, So I think probably that I would just figure that the benefits would outweigh the risks.
You said something interesting, because father and mother, parents, they are always questioning us. And that's good because there is the need of the enzyme to, to the drug to be effective.
Yeah.
So it's not going to do anything. That's another thing good to, convince them to put the kids in prolonged prophylaxis. I
think
think
also
that,
because kids, depending on their age, they may not be good at reporting if they're having a flare, because sometimes the eye may not be red, but the cornea could be, there could be stromal inflammation. So, that's another reason why it might be important for us, especially for a smaller kid who can't report, their symptoms as well.
and if you have a patient that, do not recur very frequently, but they go on vacation in a place with lots of sun and everything else, would you put them in prophylaxis?
I always tell people, like, if you're going on vacation, like, I think flights even sometimes, a sunny place, I usually bump them up. So like if they're on once a day, I'll tell them like, mate, just do twice a day for the, while you're on your vacation or whatever. So yeah, I definitely would do that.
In last question, any particular patient that you had to put in the hospital and give an intravascular medication? I mean, sometimes I face some patients with, HIV, and they are a little bit more complicated, but I don't like to put them in the hospital. So any situation, because the oral medication, the absorption is very high. So anything that you see that maybe we should put the patient in the hospital to get intravenous medication?
Honestly, I feel like for corneal disease, I can't remember a case where we've ever done that. For acute retinal necrosis, obviously it's different because those patients are gonna get IV, acyclovir. But I can't remember ever putting a patient, like an HIV patient in the hospital just for their corneal disease. I think it's, I think what something I didn't mention is like in a patient like that, what you might consider is doing both oral and topical. So we do have some patients who are on oral antiviral and they're still not clearing their, virus. And so I said that you could try switching to Fanvir, but also the other thing actually we would probably do before then is add a topical, like add Zergan or, topical ganciclovir and try to attack it both topically and orally. So that, maybe that would be like another example of a time when you could do that is for a patient with HIV.
Wonderful. So we have Professor Belfort with his hand raised.
Thank you. Great talk. And I'm going to just make some short comments. We met yesterday, and let me tell you that it's great to have Proctor back to the time it was, where we have a young leader, very good in epidemiology, and work in different countries. So having you here is strategic for us, and I'm happy that Denise is leading some researches, Brazilian side with you. We need more interaction with Proctor on that. And you are very special because you have experience from the United States, Thailand, Vietnam, and I hope now you're going to come more often to Brazil. You made some very good points that are very important that we keep in mind. First is also the use of prostaglandin-like drugs for glaucoma in spite of inflammation. This is our experience, and we have done it in many cases with excellent results, and we should really try to use these drugs. Also, the excess of indications of cyclosporine. In Brazil, I believe people overprescribe cyclosporine and compliance is not good, side effects, and we should pay more attention to what you said about steroids and steroids. So again, congratulations. I'm happy to see Proctor at that level of international leadership thanks to your work. Thank you.
Thank you very much. I feel very good to be here. I have a question for you. Does cyclosporin, are people using like 1%, or are you talking about Restasis cyclosporin, like 0.05%?
If we have to use, we use 1%. We don't use
1%.
Yes.
So you get compounded. Okay.
And we have compounding.
Yeah.
And let me ask something else. Just
also, Denise, another point that's very important, I believe, is that herpes is not the same in all parts of the world. And in Brazil, we miss good epidemiological and clinical work. I've been saying that for 10 years. And we keep repeating what is done in the United States and Europe. And Brazil probably has different strains of herpes virus, the same way we have in other disease. For instance, for uveitis, sometimes we use up to 6 grams of vanciclovir a day for a special case of iron, and we need more basic research on herpes in Brazil. Thank you.
Jeremy?
Yeah, no,
I ask a question?
yeah.
And let's just start one question that I forgot to do. There is some talk about analogous of prostaglandins, recurrence of HSV. Do you think this is something that you see frequently? Have you heard about this?
I mean, I feel like we hear about it, but in our experience, because we use prostaglandin analogs all the time for herpes, but also other types of uveitis. And I guess we haven't. No, we don't. We will use it. We don't have a problem with it, and it's not that we see, a lot of patients who are having recurrent inflammation that started. So I think, and it's just that it's a good drop. It's it's once a day. It's nice. So, and now it's cheaper. I don't know. I think I would not be so hesitant about that. I think it's like a theoretical issue, but that clinically we see doesn't end up being such a problem.
Good to know. Good to know. Zé Álvaro.
Jeremy, thank you so much for the very comprehensive talk, maybe one of the best talks I've ever heard about herpes. And my question for you is about vaccine. You are in the front of research at Proctor, and is there any advance in terms of vaccination for herpes virus type 1?
So I haven't looked into this recently, but I am not aware of any, I think there's vaccine research for sure, but it's more at a basic science level as far as I know. I'd have to look into that to see if there's any, if there have been any preliminary, phase 1 trials or anything, but there's nothing that I'm aware of. I don't know if have you heard of anything going on in that regards?
No, that's why I'm asking.
But
there is a silence about vaccines and
yeah.
But I have
and the second question.
Go ahead, Zé Álvaro.
Yeah, yes. The second question is about your prophylactic dose of valacyclovir. You said that you keep the patients with 1 gram or 500.
We do 1 gram. We'll do 1 gram once a day for just a prophylactic kind of maintenance dose, like 1 gram
1
once
gram.
a day. And then
Really?
for treatment dose, like we'll use 1 gram 3 times a day. And then kind of maybe we'll use that for like a week or two, and then maybe we go to twice a day for like a little bit, and then we'll go back down to the once a day of 1 gram. But yeah, generally we generally use 1 gram. Yeah, we don't usually use 500 milligrams. We use 1 gram. I think the idea is like, again, with that graph, it's kind of like if you use double the dose, it's going to increase the bioavailability. It's going to increase the chances that the blood levels are high enough that it's actually going to be preventing shedding at all times of day. Because if your blood levels sort of get below a certain point, and then, then it may make shedding more likely at that period of time when the blood levels are low. So using the higher dose. But also for us, the expenses now become low. I don't know what the expense of Valtrex is like.
Even here is better. It becomes much better, right? And for patients that you keep the prophylactic lifetime, as you said, you keep some patients for a long time. So how frequently you check the exams, clinical exams, like renal function, etc.? Do you keep asking exams for the patients or no?
We don't do monitoring in the way, like if we, when we use methotrexate or something, like every 3 months they're getting their blood tests. But for Valtrex, no, we don't do that. I mean, maybe we should be, but we just put them on and we don't monitor their renal function afterwards. It depends on the patient situation. If there's a patient who we're nervous about their renal function for some reason, but for a healthy patient, we don't do any blood monitoring.
Okay, thank you very much. Excellent talk.
Hi, may I ask a question? Thank you very much, Jeremy, for your lecture. And I just wonder if you have any experience with supplementation of L-lysine and to avoid the recurrence of herpes simplex.
We do have some patients who do that, but I feel like I don't have a good, I don't know of a randomized trial that's looked at it. So I don't know, it's all anecdotal, that evidence. And so I do have some patients who swear by it and they're like, yes, this is really important. And I feel like if I don't use it, then I'm going to flare, but just anecdotal. It's theoretically, there's some there's research about it. So theoretically it could have some use. But yeah, I feel like we don't have enough good information to say, if it's truly effective or if this is, more of a placebo effect or something. Yeah. But
Okay.
also, it's hard to imagine you're doing much harm, So if you have a patient who is like interested in trying something more, that seems like low risk, to do something like that.
And it's very interesting because you use really high doses, even in herpes simplex, the doses that you are using as therapeutic and prophylactic for herpes simplex, we do use here, generally in zoster. What's your regular doses in herpes zoster for a treatment, for example?
For a treatment dose would be 1 gram 3 times a day for 10 days, like around the time of the acute episode.
Uh-huh.
And then it depends.
For
So
the
sometimes
simplex, you use 2 grams.
For simplex, yeah, it depends. So like I have a patient right now who has atopic disease. And so for him, I'm using 1 gram 3 times a day.
Oh, I get it.
And he has some active dendrites. But otherwise, for a patient who, I think is immunocompetent, then maybe I would use 1 gram twice a day for a patient like that. But for any time, I have no problem using 3 times a day. Like it's it's like I said, it's a safe medication, and I would think that would be more effective actually, than using it less frequently.
Okay, thank you.
Yeah.
Jeremy, in relation to vaccines, do you think that the vaccine can boost some immune reaction in the keratitis or not?
Oh,
or would you
for
wait?
zoster, you mean?
No, for simplex. For instance, if the patient had one episode, would you wait something like 6 months to give the vaccine? I'm just wondering if the vaccine
Like
boosts,
if there was a HSV vaccine, you mean? Like if one
Yeah.
gets yeah, maybe. I mean, I think we don't know, right? Because
We
like
don't
with
know.
zoster, there have been reports, right, that a zoster vaccine will then cause a recurrence
Yes.
of zoster keratitis. So I guess it probably will depend on what how the vaccine is made and what the actual target is and that kind of thing, because that would be a risk. So I would definitely tell patients to be cautious about that. Also, yeah, I don't know. I mean, I don't know if you getting the vaccine after you already had herpes keratitis. I wonder what the benefit will be. I guess it will depend on all the research that needs to be done. Once they're a vaccine candidate.
Yeah, they want to take the vaccine because they don't want to have any recurrences. They think that the vaccine would stop the recurrences, and then that's why they want. And I always. Let's wait at least, 4 months after the last episode to take the vaccine, because I'm afraid of some sort of immune reaction, I don't know. I'm just, doing this by myself. I haven't heard anything about this.
Yeah. I would say for zoster, we definitely will tell people to wait a little bit. But then we definitely have people get the vaccine, not so much for their eye disease, but just in general, like, because, it's bad to get shingles. And then for those patients we'll have them come to the office about 10 days after they got their vaccine, just because I would sort of expect that if there was going to be a flare after them getting vaccinated, you would sort of think like 10 to 14 days later is maybe when you would actually see the inflammation. So that's the only thing different that I do. But we tell them to get it, and probably if you're having an active keratitis right now, maybe hold off for a little while. But otherwise, definitely get the vaccine and then come like 10 days after you've gotten it, so that we can look at your eyes.
Okay, great. All right. Any other questions? So thank you so much, Jeremy. It was just fantastic. Very, very productive to us. Thank you so much.
Yeah, thanks for inviting me.
Okay. All right. If you want to stay, we are going to discuss some cases. Maybe you can help us with the cases.
Sure, sounds good.
Victoria? Actually, we have a special case of herpes that may be or acantamib, I don't know. Somebody's going to present.
Fernando, vamos só trocar a ordem? Acho que a gente pode deixar os casos da córnea primeiro e aí o da lente a gente pode deixar depois. Tudo bem?
Perfeito. Ok.
Vou descompartilhar sua tela.
Tá dando para me ouvir?
Tá.
So, good morning. My name is Vitor. I am fourth year resident here in service, and I will present a case. So let's start with anamnesis. We have a 63-year-old male patient that works in a construction from São Paulo. In March 10, he entry of a foreign body in the right eye after working with a saw. In March 15, he had intense pain in the right eye and came to our emergency room. He denied any systemic diseases, and he had removal of corneal foreign bodies from both eyes a few years ago. So let's... This is the first ophthalmological examination in March 15. His visual acuity was hand motion in the right eye and 20/60 in the left eye. His anterior biomicroscopy was conjunctival hyperemia of 2+ in right eye, a cornea with diffuse edema, a paracentral corneal ulcer of 3.1 and 3.4 millimeters with a central melting and descemetocele, a formed anterior chamber with a 1 millimeter epithelium and a fibrin plastron, trophic iris, and it's difficult to assess further details. In his left eye, we saw a clear conjunctiva, a transparent cornea with central opacity, compatible with a corneal foreign body scar, a formed anterior chamber, trophic iris, and it's phakic. So for the management in our emergency room, we did a corneal scraping for culture. We start moxifloxacin hour by hour, oral doxycycline, and we put a cyanoacrylate glue and therapeutic contact lens. His right eye corneal scraping culture, we had a Moraxella lacunata and a Staphylococcus epidermidis that was sensitive to amikacina, cipro, gentamicin, oxacillin, so multi-sensitive. So the evaluation of the case, the patients report significant improvements in symptoms of introduction of eye drops and medication. So we decrease frequency of moxifloxacin and we introduce prednisolone acetates 0.12. And a few days later, he told to us a drop of the therapeutic contact lens and the cyanoacrylate glue. Here we have the first photo of our patients. The first photo is in the March 21. So we can see here the hyperemia conjunctiva of 3+, and this corneal thinning, and the hypopyon. Né? So here is an anterior UCT showing the corneal thinning. So the patients, this is the evolution of the patients. He maintains of diffuse edema, the hypopyon, and the fibrin plastron, but the pain improvements. We decide to decrease the frequency of moxifloxacin. The prednisolone acetate we put in 12 by 12 hours. We did again the therapeutic contact lens and the glue. We had several falls and we need to remake several times. In April 9, we do the glue in surgical center. And in the April 2017, we had a calm conjunctiva, the maintenance of diffuse edema, the hypopyon, and we exchanged the moxifloxacin, and we did the moxifloxacin 6 by 6 hours, and the prednisolone acetate we exchanged for 100. So the patients here, the symptoms are improvement. But in June 25, the patients came to our service with a conjunctiva hyperemia 2+, a cornea with diffuse edema, a melting appearance, and a superior paracentral and nasal thinning region, an increase of the hypopion, formed anterior chamber, and difficult to access more details. So our patient, we had an improvement, but in June, the symptoms worse. Then we ask about a possible reinfection, and we decide to do another corneal scraping for culture, doxycycline, oral doxycycline, take another cyanoacrylate glue and put therapeutic contact lens and start again with amoxifloxacin hour by hour. This is the result of the second right eye corneal scraping, and we had a Staphylococcus epidermidis, multi-resistance, sensitive only to genta and vanco. So we decide to swap moxifloxacin for vancomycin hour by hour. And now I will show several photos of the improvements of the patients. So here is the first photo in July. We can see the corneal thinning, the hypopion, and the formed anterior chamber. This is the next photo 2 days after. We can see a partial improvement of the thinning. We did the vanco 2 by 2 hours and the prednisone acetate 12 by 12 hours. I will show more photos. So this is the next photo. We can see important improvements of the hypopion. So we did the vanco 3 by 3 hours, and we removed the therapeutic contact lens. This is the last photo. He is without using lens, and we put the vanco 4 by 4 hours. We have an anterior OCT of the patients of the July. And this is the last photo of July 30. We can see the neovascularization inferior. And I want to ask about the management, and I want to finish with a question for you. So what parameters are taken into consideration when recommendation transplantation after ocular perforation controlled with glue, like these patients? So when do the transplant here?
Good questions. I think the best question is, when you have a cornea with a glue, when are you planning to do the corneal transplant, the therapeutic corneal transplant?
Yes.
I think it's for you, Jeremy.
Oh, I see. My sense is we like to just wait until the eye is quiet, and in general, if you're thinking therapeutic versus optical penetrating keratoplasty, the optical penetrating keratoplasty is going to do better in terms of just graft survival. So if there's any, it's sort of hard to tell, but there is kind of some do you feel like this eye is quiet, or do you think there's still some conjunctival inflammation inferiorly there?
I think that is quite, based on the first here. Let me see. Yeah.
So I think if you think that they're quiet, then, in general, I would say with our ocular inflammatory patients, we like them to be quiet for 3 months. So if you feel like, if the patient's quiet for 3 months, still has the glue on, but then I think you could consider, moving on to keratoplasty at that point.
And what about the neovascularization, Jeremy? Do you take it in account? If the glue is making the neovascularization coming to the cornea, that will decrease the rate of success because of rejection and everything. This is a point for you?
I guess I don't usually think of glue as being a stimulus for causing vessels to come in, like that there's something else going on. There's a perforation and that's why the blood vessels are coming in, but I don't usually think of glue as doing that. We definitely have had some patients with zoster, like neurotrophic keratitis, who've had perforation that have had glue on for months, like for a year even. And they didn't necessarily have like horrible blood vessels coming in. So I don't know. I guess my tendency would be to say I'd rather that the eye be quiet for longer in terms of like just trying to do a single transplant and not having it fail rather than being worried about the blood vessels. But that you can monitor that. I guess you can see if it seems like those blood vessels are getting worse. Okay, maybe then that will urge you to do the transplant sooner.
And Jeremy, let me ask you something. They did use doxycycline in the beginning of the treatment.
Yeah.
Do you have any feelings about doxy and isotretinoin in comparison to control of melting and those things? Because there is something that people is starting to speak about azithromycin as controlling corneal melting.
Yeah, but we definitely, when we do use that, we tend to use doxycycline, not azithromycin, and we use a lot of azithromycin for ocular rosacea and for other things. So I don't know. I guess it's like this situation where we don't really know if the doxycycline even is working. But the theoretical benefits, from the lab seem to show like that doxycycline may, have some effectiveness. So I think I would probably just stick with the doxy and not do the azithro, but it's all, there's no good evidence, I don't think, one way or the other in humans. We need better studies on vitamin C and doxy and all these things that we use them all the time for corneal thinning, but it's really not clear how much they work.
Definitely. And the use of both makes no sense because they are similar drugs, right?
Yeah, I would say to use doxy plus azithro, yeah, I would probably just pick one or the other.
Okay, good.
I have one question. How are you doing the glue? When you did the glue, there was not yet a perforation. You were sort of doing it as kind of in anticipation.
Yeah, just to support, the corneal thinning.
I think that's a good idea. Like that, I think that can definitely sometimes help halt the progression of the disease. But I was just curious, did you scrape the epithelium before you did the glue, or how did you actually do the glue?
Yeah, we do scrape all the epithelium 2 or 3 millimeters further for the last area that you can see there is an infiltration. So we go 2-3 millimeters and then we glue everything.
Okay.
You want to know? Yeah.
Dry a lot and glue.
Yeah, dry a lot and glue.
With or without a filter.
Yeah.
Got it. Okay.
Why were you asking, Jeremy? I'm curious.
Well, because it was, because it can be tricky when you have a large area to glue and then you have a large piece of glue, then it can be difficult for it to stick on and then the contact lens doesn't fit that great. And so it can be tricky in this situation, like when there's a perforation and it's a small hole, we like to use the technique where you get like a TB syringe or something and just put like a tiny, tiny little drop at the edge of the TB syringe and then put that on. But when it's a larger area, it's just harder. Sometimes people have reported using like a retinal sponge and dipping the retinal sponge in the glue and then trying to get like a nice flat layer using that way. So that's a technique that you can use. I don't know why the glue was falling off. If it was too bulky, like underneath the contact lens or what was happening, but I'm just curious how you're doing it here.
Interesting. I've never heard about this. This is interesting, this technique to put, a larger amount of glue. That's nice. And what about the new vessels, Jeremy? You always treat the new vessels, or if you have like this, it's just one single new vessel. Maybe, yeah, we should treat because one can do a big job, can give no rejection. So even if it is one, it's better to treat, right?
I think so.
Okay.
And what about if you have, are you sure that you didn't have a herpes infection, a herpes with a secondary infections? And
this-
what about doing those things, those treatments like mice or anything like that in this vessel? Should you go and do prophylaxis for herpes simplex?
I mean, I think is there, did we test corneal sensation? And is there any other, I mean, you could also do like did you test for herpes when you did the original swabs? No, just for bacteria?
No, we don't do, usually we don't do it.
Yeah, I mean, I think that's a nice idea, and certainly to prophylax is, safe for the patient, so you could do it. I guess the only issue is are you then committing the patient to sort of a very long course of acyclovir if you do that? But certainly, like the next time if it comes back, it's a nice idea. Like, why did it keep recurring, right? So is it recurring because there's some other thing going on, and it's not just bacteria. So I like that.
Yep.
I like to have that on the list on the differential, and yeah, I'd probably have a low threshold for starting.
and
And
Jeremy,
corneal sensation, Jeremy, is really hard because I like that chronic infected and chronic, it's always with diminution in sensation, right? All the infections kind of decrease the corneal sensation. And I mean, the studies in confocal, they show that it changed a lot, the innervation of the cornea. So this is something that usually makes a confusion, because you see a patient like that and we try and we measure the corneal sensation and it's decreased. And the history does not show that it could be herpes simplex or zoster. So that's something, how do you deal with that?
I guess I mean, contact lens wear can reduce corneal sensation.
Yep.
So maybe it's that the patient's in a contact lens and then they get a bacterial ulcer. So it's, so like in a patient that's not a contact lens wearer, I guess we definitely still do trust, like a decreased corneal sensation, we feel like is telling us some information. But yeah, I think it's hard in that situation. If a contact lens wearer who gets another infection, then they could have decreased sensation, but it's not from herpes, it's just from the contact lens wearer. So yeah, I don't know. You just have to take it. So then you just discount it, and especially in that case, usually it's bilateral, because they're usually wearing contact lenses in both eyes. So if you had that situation where there's a bad infection in one eye, but both eyes have decreased corneal sensation, then I would sort of say like, oh, it's probably just from the contact lenses. Whereas if it was unilateral, then that might make me think, oh, maybe it's from a herpes.
And Jeremy, when you say if you did any herpes test, are you talking about a single smears or maybe a immune reaction, something like directly immunofluorescence?
I was just thinking, like at the time when you did the scraping, if you sent for PCR for HSV.
Great. We don't do this, we have to get started doing this because we test for fungal, we test for bacteria, but we do not test for herpes. So we have herpes as, a possibility, because even if you have a bacterial, can be a secondary bacterial infection, So we have to pay more attention to herpes tests here in Paulista School of Medicine,
It's available, you can get it?
Yes, I think we can get it. It's going to be more expensive, but I think it's good for some patients,
Yeah, I would say we definitely have a low threshold. We oftentimes will sort of like, pan culture, and then part of that will be sending a swab for HSV.
Okay.
Because sometimes also you can have, like in this case, for like what we're discussing, you can have co-infection. So even if the primary infection is acanthamoeba or some bacteria or something, but it is possible to get a co-infection. So
yes, and maybe you have to treat both, maybe it's not responding because there is something else,
Yeah, exactly.
Yeah. Anybody else? So I think we are done. Great. Thank you
very much.
once again, Jeremy. Thank you.
Ah,
Another
no, thank
case
you.
for him? Maybe you have another case. Let's see. I think Laura is supposed to present a case, right, Laura?
No, I think
Okay.
no. Sorry.
That's okay. So we are done, probably. No, there is another case. Okay.
Hello, my name is Vitor. I am a first year fellowship of the Corneal and Ocular External Diseases Department here at Unifesp. I'm going to present a case. We have a patient who is a female patient, 73 years old. We first had her in our department in July 2024, and she told us she had conjunctival hyperemia and ocular secretion in the left eye in the last 2 months. Um, I forgot. She had a stroke, and after this stroke, she presented with ptosis and dysfunction of the superior red muscle and the inferior muscle in the left eye. She also had systemic hypertension and dyslipidemia. Her ophthalmologic past, she had phaco surgery in the right eye in 2019, and she also had in 2021 chronic dacrocystis, chronic conjunctivitis, and left lacrimal obstruction in the left eye. She was successfully treated with cephalexin orally and moxifloxacin eye drops. She also had a dacrocystography in 2021, showing that her left via lacrimal, I don't know, was obstructed. And
eles começaram a instaurar negócio chamado Hollywood ali poucos anos depois.
That's a picture of the dacrocystography. I don't know if you can see it, but the contrast stains only to the saco lacrimal. She did a surgery to correct the obstruction in 2023, external dacrocystorhinostomy. Okay, in the day she presented to us, her examination was best corrected visual acuity in the right eye 20/20. In the left eye was counting fingers just counting fingers. The movement of her eye in the left eye was okay. In the left eye there was a restriction of the superior rectus and inferior rectus. The anterior segment biomicroscopy, I'll show you the picture. When you see the retina, there was nothing to see in the right eye, and in the left eye, we were unable to do the exam because she had a white cataract. Her intraocular pressure was 11 in both eyes. So here we have the picture of the right eye. She had a calm conjunctiva with a pinguecular or pterygium nasally, and here are the fornices, the fornix. It's calm and there is no secretion or any reaction. Now in the left eye, she had a red eye, a much more inflamed eye. She had normal cornea, normal iris, and white cataract. The picture of the fornix, the inferior one, the superior one, we can see secretion and some papillas. I don't know how to speak that. Okay. In this day, it was prescribed antibiotic eye drops 6 times a day for 10 days. The patient comes back to us with feeling better, but not completely better. She kept the red eye. So we did a conjunctival scrape, and we prescribed flutinol, which is a weak steroid for 10 days, and we also started tacrolimus 0.03%. Again, the patient comes back with feeling a little bit better, but not completely. The conjunctival scrape showed us Staphylococcus aureus and Streptococcus agalacti, and we prescribed moxifloxacin 6 times a day and flutinol, which is a weak corticosteroid, twice a day. And we asked the Vias Lacrimais department to make a evaluation. That's the photo, the picture of the patient in this in this day. We can see there is still a red eye. We can see there is still reaction in the conjunctival, but much less secretion. And she also had keratitis, puncta keratitis inferiorly. Again, pictures. Okay, the evaluation of the Via Lacrimais department. Bottom line, they saw that there was no obstruction on the left nasal, the left, enfim, da via lacrimal esquerda. And the diagnosis was chronic unilateral papular conjunctivitis. We made a diagnosis of giant fornix syndrome, em português, a síndrome do fornix conjuntival profundo. We prescribed azithromycin 1 gram a week for 3 weeks, and lubrificant eye drops. I'm going to talk a little bit about the giant fornix syndrome. It's a rare case. It's inflammatory and infection, and it's much more common superiorly. It's associated with deep conjunctival fornix, bacterial conjunctivitis, and it may be associated with ptosis and dysfunction of the MAPS, which is the, enfim, músculo elevador da pálpebra superior. This dysfunction of the MAPS may be caused also by age. It's a condition almost exclusive of the elderly patients, most likely in the 70 years or 8 years. It's much more common in women too. The reason, the etiology of the diseases, it's not quite sure, but they talk about deep conjunctival fornix, creating a good environment for bacterial proliferation. And they also talk about the obstruction of the lacrimal ducts, generating larger biofilm. The physiopathology of the diseases is that the bacterial proliferation leads to toxicity in the conjunctiva. So the conjunctiva have an exudate, and this exudate protects the biofilm of the treatment or whatever. And the biofilm keeps growing and keeps generating more toxicity, which keeps making bad to the conjunctiva. The most common etiologic agents are Staphylococcus aureus, but Pseudomonas aeruginosa and Serratia marcensis have also been isolated. About the clinic of the patient, it's a chronic purulent conjunctivitis. It's recurrent. It's usually unilateral, but it can be bilateral, and it's associated with deep conjunctival fornix. It may present regular symptoms of conjunctivitis like red eye, pain, foreign body sensation, blurry vision, and in this case, ptosis. If you don't treat and you have, how can I say, this disease for a long time, it can lead to corneal damage like keratitis punctata, punctato keratitis, thinning, and corneal perforation. We can also see pseudomembranes. The diagnosis usually is talking to patient, having a good sleep lamp examination, and the CT can be useful. It can show air in the deep conjunctival fornix superiorly. but a normal exam does not exclude the diagnosis. So it's just something to, I don't know, acrescentar. The treatment of the case, that you can use several therapies. It's not quite sure. The disease is quite recent. The first time they talk about it was in 2004, so we don't have a defined therapy, but you can use systemic antibiotics, topical corticosteroids. You can remove the secretion of the deep fornix using a cotonete or swab. You can also do it with a solution of iodopovidone. You can use subconjunctival antibiotics, soro-autólogo eye drops, and you can also do surgery, which is resection of the conjunctiva. In the initial cases, you can treat it with systemic antibiotics and high doses of topical corticosteroid and antibiotic eye drops. In moderate cases, it may need long-term use of corticosteroid and antibiotic eye drops to avoid recurrence. In moderate to severe cases, you can also use the cleaning of the conjunctiva with the swab with iodopovidone. And severe cases is the surgical treatment, which is a resection of the conjunctiva, usually 4 to 10 millimeters. And they say it has very good results. And the larger the surgery, usually the better result. Complications, if we do not treat, it's thinning, ulceration, and corneal perforation. And that's it. Thanks so much.
Jeremy, I have never ever heard about this kind of problem in the eye. And when they brought these guys to me, I said, well, okay, I have 40 years in ophthalmology and I never ever saw a case like this. And then came to my mind, maybe some of the red eyes that we see, maybe they have, more pronunciated cool-off sac. I don't know. But do you have any experience with this thing?
Yeah, we do like diagnose this from time to time. I guess I feel like I agree, like in older patients, usually the giant fornix is pretty obvious, like that there's dehiscence somehow, and I didn't see an external photo, but you can usually obviously tell, like it's a problem. Sometimes we have a problem where we diagnose it in patients who don't have a classic giant fornix, so then they have this giant fornix syndrome, but without the giant fornix. But I think the key feature for me is that there's like a lot of mucus and pus. So especially like when you evert the upper lid, if you see like a pocket of pus up there, I feel like that is very indicative of this condition. So yeah, and I think the diffuse papillary reaction in the especially in the superior lid and the pus. I would say I don't know, the zithromycin is interesting. We usually give Cipro. I don't know why. I think maybe some of the original reports talked about Cipro. So we usually do Cipro orally, and then we give fluoroquinolone and a topical and Predforte, topical steroid 4 times a day, and we do that for a month. And then usually it gets better after that. But then the problem is when you stop that treatment, oftentimes it can come back. And so we'll like repeat it, but then oftentimes they need surgery, and then we'll send them to the oculoplastics, like as the presenter was saying, and to excise some of the fornix.
And if you keep the patient on artificial tears with high frequency, could that help? I mean, anything that
I'm not sure why. I don't know what that would do, like I feel like they probably in some sort of way, it's I don't know, for us it seems like it's more the antibiotics and the steroid, like both of them that are useful.
Mm-hmm.
It seems to me very similar to flop eye syndrome, but it's a bilateral, superior and inferior, but it should be like flop eye syndrome. But I don't feel very comfortable saying that it's really a giant fornix before doing any kind of biopsy. In this case, it seems very strange. Would it go to a biopsy before close the diagnosis in giant fornix?
I guess, I mean, I think the giant fornix, I don't think of a biopsy, but rather just if there's actually like space, if there's space in the fornix. So like if there's been dehiscence and there's space in there. Yeah, but I think I don't know. Yeah, we don't do a biopsy. The other thing for this patient, I think the one photo showed it didn't look floppy. I don't know if the clinically the patient had floppy
No.
lids, but
Yeah, no, didn't look floppy, but I mean, it's supposed to be like floppy, but in superior and inferior lids. It's this physiopathology, something like that. But for me, it's not, it seems strange. Too much conjunctival edema, chemosis, and it seems to be like a different tissue growing in this tarsus. It's why I would like to have a
I see what you're saying.
yeah, a biopsy and also some hematologic exams to see if there's no hematologic disease associated with this. I know that he has stroke and everything, but it doesn't seem only, it's strange. Did she get
But
better?
his other eye looks normal.
Normal.
The superior
That's the
conch.
point, Jeremy, because
Completely normal.
bilateral, the condition is supposed to be bilateral, and the symptoms are so much more frequent in the left eye. So it's just strange, I didn't.
But he had the ptosis only in the left eye.
Yeah.
I don't know. I mean, I could because there's some structural thing happening because there's a ptosis in that left eye. There's something structural and anatomical happening, and it could be creating some problem anatomically that could be causing this to happen. I think it's feasible.
Volta mais uma. Lá na primeira.
I didn't.
Sorry.
I think there is something else. I didn't buy the diagnosis,
Yeah, me too. I would go to a biopsy and look for some hematologic exams.
Self-inflicted, there is something fishy in this case. I didn't buy it.
See, too much.
If there's hematologic, I would expect to see it in both eyes, though, right?
Yes.
Yeah.
I don't know.
I don't know. I guess you could do a biopsy, but it is very pussy up there in the superior. Yeah.
Look, too much tissue here. It's granular tissue, something strong. I mean, strange. It could be a tumor or anything like that.
And I agree, Luciani, with Jeremy, because I think a biopsy is not going to help me, Either it's something anatomic, so I have to do the diagnostic examining, or maybe, I don't know, I have something with self-inflicted.
I just want to run out any hematologic disease or tumor. That's it.
Yeah.
It's why I would like to have a cytology or even a biopsy, incisional biopsy.
Good. Brazilians cases, Jeremy, you see, we face those strange things here.
I mean, I don't think I can't fault you for getting a biopsy. That will just give you more information, so that's good. But I'd be curious. I'm curious. You just started him on the oral antibiotics recently?
Sorry.
Como é que ele estava? Como é que ele melhorou? Como é que ele está?
Yes, this patient is feeling better, but not completely better. There is no secretion anymore, but there is still a red eye and epiphora, or I don't know, lacrimejamento.
Tearing.
Tearing. Yes.
I mean, the redness will take some time. You could consider doing the topical steroid as well. I think you had a weak steroid, but you could do a stronger steroid. I mean, if you do a biopsy, fine. But then after that, if it turns out it's nothing dangerous, you could consider doing a stronger, like a 1% prednisolone type of steroid.
Yes, she never got to use strong steroids, just weak steroids, and never did a long-term use of, I don't know, antibiotics eye drops and steroid eye drops. I mean, for like a full month, she never did something like that. And I don't know, reading this article yesterday, I thought it would be a nice try to remove the secretion with the swab and iodopovidone. I don't know, just a try.
Esse continua.
definitely, go ahead.
Vitor, this
Wait.
tissue is still there? Is this tissue still there?
The tissue,
Yeah, esse espessamento maior na borda palpebral? Ainda tá lá?
in the last time we saw her, less, but
Here.
yeah, it's still there.
Still there. A little bit of improvement, right?
Yes, a little bit of improvement.
One thing just about the povidone iodine, we've tried that sometimes. It's not always effective, but when it has been effective, we've usually brought the patient back every week. So it's not like you do it once. It's like you have to bring them back every week and do it, and you have to get way up there, like with the swab into the fornix when you're rinsing with the povidone iodine. So
Yes, it's supposed to be done several times, as you said.
5%, Jeremy? The iodine
that
povidone is
sounds right, but I don't know. I would look at the paper and see what they used, but that sounds right.
okay. And we have a question here from a friend that he is asking, if you put a patient on prolonged use of tacrolimus, would you give oral prophylaxis against herpes?
Topical tacrolimus?
Yes.
I guess
Or
no.
treating
I would,
immune reaction, corneal immune reaction.
I wouldn't. I mean, that I wouldn't have thought of that unless no pre-existing herpetic eye disease.
It is a herpetic eye disease.
Oh, someone who has existing herpetic eye disease, but you're giving them tacrolimus for the herpes, or you're giving.
Yeah, to control immune reaction. Topical tacrolimus to control immune reaction.
Yeah, I mean, I would say in general, we treat everyone who has herpetic eye disease. We give them oral antiviral. So yes, I would cover them. But I think in that case, more so just like for a general prevention, with or without tacrolimus, I would treat them with oral antiviral.
Okay, good. All right. Any other questions? Any other case? I think we have just 2 cases, right? Yes, I guess so. All right. Thank you so much,
Thank you. Very interesting. I enjoyed taking part.
I hope you can come back and stay a month here discussing our cases.
Sounds good.
I'll see you soon. Bye-bye.
Good, bye.
Thank you.
Obrigada, pessoal. Vou encerrar a reunião.